Okay. Now, Victor, I met this young man with our national meeting, and Victor, I'm going to give you, let you give all your pertinence, as I'm part of the Prostate Cancer National Canadian organization or foundation as well. And he gave us a presentation on pharmaceuticals, and I'll get you to briefly discuss that and what's pertinent here in Saskatchewan. Victor, please introduce yourself, sir.
Well, hello, thank you for having me today in this meeting. My name is Victor Varkessels, and I'm a fourth-year student at University of British Columbia. I was invited here in order to discuss the types of medications and treatments available for prostate cancer patients, and diving a little bit more deep into the treatments and accessibility for medications within Saskatchewan.
Okay, now, do you want to share screen, Victor?
For sure. I'll share it right now. 1 second.
And Victor, for your knowledge, about 1, 2, 3, 4, 5, 6, 7, 8, 10 people in the room, and there's 8 people online.
Sorry? Is everybody able to hear me? Hello?
Yeah, the sound is fine.
Oh, the sound
Okay.
is fine? Okay,
It might be our
Wonderful.
internet.
If there's
okay.
if there's any problems, just, let me know, and then I'll be sure to say anything again, just in case nobody heard it. So,
Okay, great, thanks.
yeah, of course. So as I mentioned before, I'll be discussing the different kind of medications available for prostate cancer patients. And I'll begin with a brief outline about what we're going to be discussing in today's presentation, starting with prostate cancer and how it originates into people and what could be the causes for prostate cancer in patients. Different kind of treatments, main treatments available to patients, such as hormone therapy, radiation therapy, chemotherapy, and finally, where patients can treatments and medications within Saskatchewan. I wanted to begin with discussing prostate cancer and its etiology. Basically, what happens is that we have something called androgen receptors that are expressed on these prostate cancer cells, on the surface of these prostate cancer cells. And there is certain agonists so-called, known as androgens, such as testosterone or dihydrotestosterone. Dihydrotestosterone may not be so familiar for many of you, but testosterone, I'm sure you've heard about before. These molecules bind to this androgen receptor and elicit a cellular response that travels to the nucleus of these prostate cancer cells and causes them to increase their cell growth and division. Mutations on these prostate cancer cells can result in androgen receptor overexpression on the cell surface, which can itself result in uncontrolled cell proliferation, forming a tumor. And this is because the more androgen receptors expressed on the cell surface of these prostate cancer cells, the faster they will be able to grow and proliferate if androgens like testosterone or dihydrotestosterone bind to these. I wanted to first discuss hormone therapy as one of the treatments, like one of the main treatments available for prostate cancer patients. And hormone therapies are known as androgen deprivation therapy or hormone replacement therapy. They're known for many names, but they basically work directly or indirectly on these androgen receptors, and they reduce the quantity of androgens, implying testosterone or dihydrotestosterone, present, which means that we can block the binding of testosterone to these receptors. And so it can reduce the growth and cell proliferation of these prostate cancer cells. Hormone therapy alone, however, can't be proven to be very effective at killing the cancer cells, since hormone therapy isn't able to kill the prostate cancer cells. In fact, they are able, however, to help shrink the tumors and prevent them from growing and proliferating. Hormone therapy is therefore added in combination with other forms of treatment that we will be discussing later on, such as radiation therapy or chemotherapy. And these can kill the cancer. Firstly, I wanted to discuss the different kind of hormone therapies, and I'm sure that you may be familiar with many of the names and brand names listed over here. As you can see, hormone therapies are known for many names, as like hormone replacement therapy, or in some cases as androgen deprivation therapy. Firstly, we got something called AHRH agonists, which you may recognize as Zoladex or Eligard. And these come in a variety of doses and concentrations, which can be available through the wide provincial coverage programs and federal coverage programs. LHRH agonist is basically something that mimics testosterone and something that pretty much binds to its receptor. This is not the same as the androgen receptor. This is a different kind of receptor. Agonists bind to this receptor, and it stimulates the release of hormones known as luteinizing hormone and follicle stimulating hormone. Now, these are very important because the increasing the release of these hormones causes a cascade of release of testosterone. And so you can understand that perhaps by using an agonist, which is a drug molecule, and allowing this drug molecule to bind to these receptors, we can cause the stimulation of these hormones, the LH and FSH, which eventually will lead to the receptor becoming desensitized. It's slightly counterintuitive how this mechanism of action for the drug works, because it's initially stimulating the release of and production of testosterone. However, the body has to maintain regular levels of hormones in the body, and so once it encounters that it's stimulating that these hormones are stimulated, the body will kind of desensitize this mechanism of action and no longer actually allow for the production of testosterone. It will inhibit it. So this will result in the suppression. This agonist binding to the receptor will result in a downregulation that will cause a suppression of LH and FSH, eventually leading to the prevention in production of testosterone. Now, I've mentioned before that testosterone is important and is needed in order for prostate cancer cells to grow. Without testosterone or dihydrotestosterone, these cells cannot gather signals that eliciting for the tumor to grow and proliferate. And so by reducing the testosterone levels, we can safely suppress the growth of the tumor. Many examples of LHRH agonists are Leuprolide, known as brand names of Lupron, Lupron Depot, Eligard, also Goserelin and Triptorelin. I'm sure you guys have heard of these in the past, and there's many others as well that I haven't included in order to for simplicity purposes. Moving on, we also have something called LHRH antagonists, and unlike the previous one that was named antagonists, the antagonists bind to the receptors, and instead of allowing for the stimulation of LH and FSH, which eventually leads to a desensitization and downregulation of testosterone, in this case, LHRH antagonists will bind to the receptor, stimulate LH release, and prevent the production of testosterone. They block the receptor and no longer allow it to be able to release these hormones in order to make testosterone. So as you can see, this option is a faster route compared to agonists because we no longer have to wait in order for the receptor to become desensitized. And a common drug molecule known to work this way is known as Degarelix or Firmagon. And again, this is provided in a numerous number of dosages and routes of administration. However, it's usually given through an injection. We also have something called androgen synthesis inhibitors. And all of these are hormone therapies but there are different classes of hormone therapies. They work to target different receptors and different sites in the body. So androgen synthesis inhibitors, such as abiraterone, which is very known and it's known for being Zytiga. This one is administered usually in tablets. However, it could also be administered through other methods. And how this one works is that testosterone and dihydrotestosterone, as I mentioned, are different kind of androgens that bind to androgen receptors to promote growth. And so androgen synthesis inhibitors will target the enzyme responsible for converting testosterone to dihydrotestosterone. This is where dihydrotestosterone comes into play, as dihydrotestosterone has 5-fold higher affinity to the androgen receptor compared to testosterone. Now, companies try and focus on targeting this dihydrotestosterone because it has such a high affinity to the androgen receptor compared to testosterone. Therefore, targeting this dihydrotestosterone will prove to be able to reduce the cell growth of the prostate cancer cells more effectively. If there's any questions during the presentation, please feel free to let me know as well. And yeah, so this is androgen synthesis inhibitors such as abiraterone.
Yeah, I'm going to ask you a question right there, Victor. If you don't
Of
mind,
course.
with now the DHT, now that, if I understand you correctly, that is testosterone, but it's processed in the prostate. And once it's processed in the prostate, does it increase its I don't know if you want to call it strength,
Right.
or can you explain that, please?
Of course. So testosterone, as I mentioned, is made once the body realizes that it needs to make more of it. And this is like a regular body process, especially, well, yeah, in males, because they have high levels of testosterone. And once testosterone is produced by LH and FSH hormones, testosterone, an enzyme will convert testosterone into dihydrotestosterone. It's just a regular process that occurs in the body, and we are we want to block this conversion of testosterone to dihydrotestosterone, because the latter one, DHT, actually has a much higher affinity for the androgen receptor compared to testosterone. And this affinity to the androgen receptor implies that the more of it binds to the androgen receptors found in prostate cancer cells, the faster the prostate cancer cells will be able to grow and differentiate. And if these are not targeted effectively, or targeted but the body is the body's still fighting against the cancer, the tumors can eventually metastasize or become resistant to medication. And so it's important to use medications in order to treat the cancer as soon as possible. But however, the type of medications used will vastly depend on the stage of the patient's cancer.
Mm-hmm. If I hear you correctly, it's like having a gasoline and throwing it onto a fire to enhance it. That's the DHT.
Correct.
There we go. Okay, thank you.
No worries. I'll continue now. Finally, not finally, but one of the last kind of hormone therapies is, and one of the most effective indeed as well, is androgen antagonists. So unlike the LH-RH agonists or antagonists before, these are binding, these androgen antagonists bind to a different kind of receptor known as the androgen receptor. And as I mentioned before, this receptor is important because androgens like testosterone or dihydrotestosterone will be actually binding to this androgen receptor. And so we have to use antagonists that will block these receptors from binding to testosterone or dihydrotestosterone and prevent cancer cell growth. The difference of these two LH-RH receptors is that LH-RH receptors occur far sooner in this process, and it's the LH-RH receptors that will stimulate the release of LH and FSH, and these will lead to the production of testosterone. So androgen receptors come after, and LH-RH receptors come before. If there's any confusion between these kind of receptors, you can feel free to let me know at the end of this presentation. I'll be happy to explain further. And examples of these kind of androgen antagonists include many of these. I'm sure you've heard about these before, or perhaps used them in the past because they've been so effective. And since they've been pretty much so effective because they directly bind to the androgen receptors as opposed to going to other forms of receptors or other sites of action, and they directly block these androgen receptors, hence directly preventing the growth of these prostate cancer cells. Excuse me. Finally, we also have something called orchiectomy, which is completely different to the other forms of hormone therapies, as I discussed previously, as this one involves a complete surgical removal of the testicles, and such a surgical procedure will reduce testosterone levels a lot. The pros of this option is that it's been known to be very cheaper than the other ones, and it's a simple form of hormone therapy. However, the great disadvantage of this form of treatment is that it involves a permanent, non-reversible surgical castration. And so many patients are very hesitant to undergo such procedure because of its unreversible process. Now I wanted to move on to radiation therapy. And what I wanted to discuss actually before moving on to here is that all of these hormone therapies that I've discussed on here, they've been shown to be great at treating and helping patients. However, in some cases, some prostate cancer is able to undergo certain mutations, because prostate cancer is tumors such as prostate cancer. They grow uncontrollably, and they're able to do this in a way in which these cancer cells are just growing without any sort of control, and resulting in many mutations arising on these cancer cells. And the issue with mutations arising is that if we're trying to fight the disease with a medication, the cancer is able to propagate regardless and able to mutate in a way that it becomes resistant to these sort of medications. And this is one of the great reasons why treating against cancer is so challenging, because cancer has so many different pathways in order to grow and differentiate, that perhaps blocking one of the mechanisms in which it grows using hormone therapy may prove to be efficient enough in order to terminate with the cancer. And so that's why it's important to also look at other forms of treatment, such as radiation therapy. And unlike hormone therapy, radiation therapy is used as a monotherapy or in combination, but it's able to destroy the cancer cells using high energy rays or particles. Unlike hormone therapy, which is responsible for shrinking and minimizing the growth of the prostate cancers, radiation therapy is able to use high energy radiation to target effectively the tumor in order to kill it, without minimizing the damage to neighboring normal cells in the body. So why radiation therapy? Well, radiation therapy is very effective because it destroys the cancer cells in the body. It also treats cancer that wasn't removed with surgery or that is recurrent, because surgery could be great, could be really effective to reduce or remove the tumor. However, in some cases, which you guys may have heard in the past, that there's still a small portion of tumor remaining in the person after the surgery, because not all of it was able to be moved, or the procedure didn't go as effectively as expected. And having a small portion of this cancer remaining in the body, even after surgery, can still to be very dangerous, because it can allow for the prostate cancer and for the cancer to propagate and become recurrent and metastasize to other areas and become. That's why it's so problematic and difficult to target this cancer, because it's so easy for it to appear out of nowhere suddenly. Radiation therapy is also really effective because it relieves the pain or to control the symptoms of many advanced prostate cancers. And so having something that can relieve patients from their symptoms is also very important, as we should always address how we can reduce their symptoms, such as erectile dysfunction or incontinence or other sorts of symptoms that commonly experienced in our patients. There's a large variety of radiation therapies available, and the two main ones are external beam radiation therapy and brachytherapy. External beam radiation therapy is the most common form of radiography and radiotherapy for treating cancer, specifically prostate cancer. And it involves using a large machine that can release a beam of radiation through the skin and into the target site inside the body. And so there's a lot of differences between external radiation therapy and brachytherapy, but external radiation therapy is one of the most well-known, and it's very common in hospitals in order to treat patients, especially if their cancer is metastasized, advanced, or is recurrent. And these radiations will penetrate through the skin and target the tumor. In most cases, there will be some sort of optimization with these machines in order to ensure that only the tumor is targeted. However, radiation therapy uses high radiation and isn't as selective as other forms, such as brachytherapy. And so many cells in the process may experience some sort of damage as well, even though they weren't meant to. It's kind of like a side effect for many treatments. And external radiation therapy can be given in combination to other things, such as chemotherapy or hormone therapy, as they can work together in order to fight against the cancer. And also note, radiation therapy is usually offered in older patients in an older demographic, and it's especially used for patients who can't undergo surgery due to the complications that could arise in this case. And so even though it sounds like it's a very invasive process, surgeries tend to be the most invasive forms of procedure against prostate cancer, as sometimes they involve opening the patient to extract the tumor. And so using radiation from an external source to target the tumors has been proven to be pretty effective at treating the cancer. The types of external radiation therapies available, there's many more. However, I wanted to keep the list concise and discuss some of the ones that are over here, such as standard external radiation therapy, which is the typical one that is known. However, we also have something like 3D conformational radiation therapy, and although this may sound a bit complicated, it basically involves using a 3D imaging of the tumor and conducting it using something like a CT scan or an MRI. And after an image of the tumor has been made, the healthcare professionals will do something, will basically start the beam of radiations using a linear accelerator. It just basically accelerates the energy in order to produce the beams that will then be targeted to the patients in order to fight against tumors. And we also have other forms such as proton therapy. And proton therapy works differently to these other ones because it doesn't use the same kind of radiation as these other ones. Instead, it uses high energy protons that will become excited and undergo effects in the body after some time, after a certain amount of time. So the proton therapy, the machine will release these high energy protons, and it won't be until it touches the tumor that it will elicit an effect in the body. And so this allows for the neighboring cells around that are not cancerous to not be as affected by this radiation therapy. Therefore, it's been heavily researched and used in many facilities. Secondly, we have another form of radiation therapy. This is brachytherapy. And so compared to the other one, which was external.
Oh, you froze up, Victor.
Come back.
The tumor, and it is able to target directly cells. This increased selectivity allows for higher doses of radiation to be used against the target site, as opposed compared to external radiation. And so since we have a higher selectivity, we're able to reduce the risk on neighboring cells and damage to unwanted cells. The pros of this form of radiation therapy is that since it targets a smaller area, because it's more selective, we can use higher levels of radiation, which won't be more dangerous just because it won't be more dangerous. And that's because this therapy will be more selective to the cancer instead of damaging neighboring cells. And so by using high level radiation, we're able to fight against the tumor at a faster rate, implying that we have to do treatment sessions and hence a shorter treatment time overall for the patient. We also have a more novel approach, which is known as targeted therapy. And this type of therapy, known in this industry, uses drugs such as small molecules to target things like proteins found on the inside or outside of these cancer cells. They tend to be on the surface, but these small drugs will be able to target these small molecules. And these small molecules, like the proteins, are able to send signals across the cancer cell in order to tell it to grow and proliferate, same as how we discussed initially in the presentation. And so by targeting these proteins with these drugs, we can effectively block the signals to prevent the cancer growth and limit its propagation, as well as limit the damage to normal cells, because these are selective to proteins expressed on prostate cancer cells, unlike other cells. These forms of targeted therapy are used to treat against stuff like metastatic cancers that have been able to escape the prostate and attack other areas of the body, which is something that we don't want, because we want to localize the cancer and make sure that we can properly, adequately target it to reduce the risk of it propagating to other parts of the body. And so we can target these metastatic cancers that have become resistant to hormone therapy as well, due to the specific mutations that may have arisen. As you may know, there's a common stage of prostate cancer is metastatic castration-resistant prostate cancer, and this is a form of prostate cancer that has become resistant to hormone therapy, and therefore we have to take on other sorts of approaches in order to treat the cancer, such as radiation therapy, or as a last resort, chemotherapy. Examples of targeted therapies include olaparib, which is used when there are gene mutations in the prostate cancer cells, allowing them to become resistant to hormone therapy, or niraparib combined with abiraterone acetate, which, as I mentioned before, is an androgen synthesis inhibitor, which is a hormone therapy. And this combination is given when there's a mutation and chemotherapy cannot be used, as chemotherapy may be too invasive for the patient, or perhaps it's since it's a last resort, we don't want to opt to using chemotherapy so early, so we would decide to do something like targeted therapy.
What form of Victor?
Yeah.
What form of genetic mutations are the personalized medicine used for? Can you highlight a couple?
Can you repeat that? Sorry.
Like what genetic mutations or cancer cell mutations are the personalized medicine or the targeted therapy used for? What gene
Right.
mutations?
Correct. So the thing is that, for example, drug molecules, as I mentioned, may be binding to these androgen receptors in order to block the production of the increased growth and proliferation of the tumors. And so a mutation can perhaps cause the cell receptor to change shape and prevent drug molecules from being able to bind to such receptors. So these mutations can kind of act as a protective mechanism for the tumor and prevent drug molecules from being able to bind to these receptors. And so these kind of mutations, excuse me?
Sorry. BRCA2, and if I remember correctly, BRCA2 is one of those common. And oh gee, well, HOXB13AR, like some of the gene mutations that it really works well for. That's what I'm getting at, like some of the genetic mutations.
Yes, so there's a lot of genetic mutations around there, and as you mentioned, some of those are considered some of the main ones as well. But that's the issue. If we have a tumor that is growing uncontrollably, there's a lot of mutations that can arise, a lot of random mutations in the tumor, and the number of mutations that can happen is pretty much infinite in a sense. There's a lot of things that could go wrong, and that's why, again, it's so complicated to sometimes, in some cases, treat these patients, especially if there are late stage cancers.
Exactly, and thank you, because we do have some folks here that have genetic in their family, so I just wanted to point that out, that this is good for.
So I have a question, and it has to do, like, I've heard targeted therapy referred to as gene therapy.
Yes.
Is that, have you heard that? And is it really gene therapy, or is it targeted therapy? Is it targeted gene therapy?
Right. So with targeted therapy, we're basically targeting like kind of like, thing is that every cell, like in our body, we have something called proteins, and proteins are made from our DNA. Our DNA is extremely big, and the expression of certain genes in our DNA will allow us to generate certain proteins. Now, all of us have the same. Oh, hello? Can you hear me?
Yeah, we lost you there for a little. Yeah, now we can.
Sounds good. I'll repeat myself. The body has something called DNA, and it's present in the nucleus. And DNA contains a large number of genes that may be expressed in certain people and maybe not expressed in others. And these genes, if expressed, they will be responsible for doing a whole mechanism that will lead to the production of certain proteins. Now, cells secrete these proteins, including prostate cancer cells. And so by these targeted therapies, in fact, target these type of proteins. And these proteins are not things that are potentially found in other kind of cells, because the same proteins are not produced in prostate cancer cells like this, around the body. Proteins are produced in prostate cancer cells, and those same proteins may not be produced in other forms of cells in the body. And so this allows for a higher selectivity. However, with gene therapy basically kind of like targets these genes and prevents them from being expressed. And so by targeting the expression of these genes found in DNA, we can effectively not even like target the proteins, but inhibit the body from making these proteins. And these proteins may be very, very relevant in order for the cell to survive. And with gene therapy, what they're basically trying to do is to target the genes that make important cancer cells, so that we can suppress the protein and prevent the cells from growing and eventually dying. Targeted therapy will target the proteins that I've already made. And so it's a little bit distinguished to gene therapy as far as I'm concerned. However, I would have to maybe look it up after this presentation if you would like to know more about it. I wouldn't want to misinform you either.
Yeah, because from
Hopefully
what I
that answers
understand,
your question.
yeah, Dr. Shivra from the Vancouver Prostate Center has studied this quite a bit, quite in depth, and BC is a place to go for together. So thank you.
Right, of course. Moving on, we have chemotherapy, which I'm sure everybody knows about. And this type of therapy is known as a last resort for patients due to its invasiveness and large effect in the body all across. Chemotherapy, however, is very effective because it can destroy the cancer cells. And how chemotherapy works is that it targets cells that are rapidly growing. And so any cell that is rapidly growing in the body will be in some way, shape, or form affected by chemotherapy. This is one of the main reasons why a lot of patients taking chemotherapy suffer from hair loss, because hair cells grow very rapidly. And so any cell that grows rapidly will be, in fact, affected by chemotherapy. So you can see how chemotherapy, although it can effectively target cancer cells, is not as selective. And so it will also destroy other normal neighboring cells around the body, which can be very, very scary, in fact. And so that's why chemotherapy is in some cases used as a last resort, because healthcare practitioners don't want their patients to sometimes undergo this, but in some cases it's necessary and it's the last resort. However, I haven't included in my presentation, but a lot of research is going with regards to chemotherapy and radiation therapy, and being able to use substances and bind these type of therapies to other drugs in order to increase their selectivity, so that they are not actually targeting rapidly growing cells, but rather just selectively damaging the cancer cells that we're interested in. And there's a lot of research undergoing in this area of knowledge, and there's a lot of promising results, which perhaps may be able to give us some new treatments available for prostate cancer patients and other cancer patients overall, in order to try and fight against the disease. Examples of well-known chemotherapy agents are docetaxel combined with darolutamide, and the chemotherapy here would be docetaxel, mitoxantrone, and cabazitaxel, known as Jeftanah. And as you can see, there's different different routes of administration, such as taking the intravenous use over here. So why chemotherapy? Well, as I mentioned, it can be used in combination with hormone therapy against very late stage cancer, prostate cancer, such as metastatic castration sensitive or metastatic castration resistant prostate cancer. And it's also being used in palliative care, funnily enough, as it can be used to relieve pain and control symptoms of metastatic prostate cancer. Finally, I wanted to discuss where we can access these medications, as knowing about the medications is very important, but knowing how to access them within your province can be proven to be just as important as well, since it's important to know where you can access these medications and where you can find help, so that they can help you out in your cancer journey. And with regards to provincial programs in Saskatchewan, the main ones is the Saskatchewan Cancer Agency, that offers a drug formulary online where you can access all the different kind of prostate cancer treatments available to patients, as well as treatments against symptoms of prostate cancer, such as incontinence and other forms of symptoms. also prescription drug plans and health coverage, as well as the Community Oncology Program of Saskatchewan, which offers treatments such as radiation therapy as well, and chemotherapy. And there's also a number of federal programs as well, such as the non-insured health benefits for the First Nations, and as well as the Veterans Prescription Drug Program and the Canadian Armed Forces Program. All of these are federal programs available for patients and minorities and smaller demographics of patients who may not be able to access medications through provincial programs. They still have certain options available in case they want to try to look for other forms of accessibility. Finally, we also have manufacturing patient programs, and these are offered by the drug manufacturers responsible for synthesizing and developing and launching these medications. In some cases, although mostly seen in the United States, these because they have a more of a private healthcare, manufacturing companies will in some cases fund for the use of use of their medications on patients, and patients may apply for these helps from the manufacturers. Again, if patients would like to access a lot of these provincial or federal programs, in most cases, it goes on a provincial to provincial basis, and it depends where you are. However, we have a public healthcare system which is able to help our patients in most cases free of coverage. But there is, however, other treatments available which are also involving radiation therapy that in some cases are not provided free of charge to patients, and so they can access these medications on a paid by pocket basis. So services covered, as I mentioned, all cancer surgeries are performed within Saskatchewan by the Saskatchewan Health Authority, and they're covered with a valid Saskatchewan health card. And then Cancer Agency will pay for all approved cancer drugs for patients with valid health cards and registered with the Cancer Agency. This includes drugs administered by injection or oral cancer treatments taken at home as well. And a lot of the services covered include radiation therapy, which is both external and internal radiation therapy, also known as brachytherapy, cancer medicines such as chemotherapy or hormone therapy or immunotherapy. There's also surgery available, stem cell transplants, and combination of other treatments as well. These paragraphs I extracted from the Saskatchewan Cancer Agency. And if you would like to learn more about the information that I published in this presentation, feel free to email me. This is my email where you can contact me with any questions, and I would be surely very, very happy to help anybody who and thank you very much for your time.
Thank you, Victor. And yeah.